Hi, my name is Tanya and I'm a family physician. I would like to share a story of my friends who are in different types of medical practices but have all transitioned to a value-based care model. There are many definitions for value-based care, such as performance-based and accountable care, but the premise is the same. It is healthcare which offers payment based on quality outcomes. Value-based care is results-driven medicine. This style focuses on the holistic care of the patients, whereas the fee-for-service model focuses on episodic care. Fee-for-service medicine is imploding because payment is dependent on the quantity of care rather than the quality of care and its effectiveness. While still in its infancy, value-based care can mean more resources, time, and dollars for physicians. For our patients, it can mean better care, better experience, and better outcomes. We as physicians and our relationships with our patients is what drives value-based medicine to improve health outcomes. Therefore, value starts with us. I am meeting my friends Bree, Jeffrey, and William, who are also in family medicine, to talk about our experiences as our practices move through the value-based care continuum, focusing our discussion on the bonus program, shared savings, and the full value relationship. I would love for you to join us and be part of the conversation. So hey everyone, how are you doing today?
Doing well, Tanya. Thank you.
So I'm glad we get to meet again and share the changes in our value-based care practices since we last talked. We mentioned it's a broad term where payment is offered in a variety of ways, so I can't wait to discuss that further and hear your experiences. Bree, I remember that you were excited when you first heard that your practice was moving to value-based care. Tell me about that.
Yes, it's going great. If you remember, I had joined a large physician-led practice 7 years ago, and we are currently in a full risk model, which has taken us the past 5 years to get to. First, we started in a bonus program and advanced to a shared savings program until we finally moved into a full risk model. The transformation was not as difficult because, as a group, we were involved in deciding which quality measures to focus on, how to build up staffing, and how to allocate savings, if any. We really noticed the benefit once we took on the full responsibility of our patients' outcomes and cost.
So I'm curious to learn more about how you got started.
Well, we had started out receiving bonuses for meeting certain quality goals, and this helped us to focus on creating a simple workflow, preventative measures, and improving our method of how we track our patients with different diagnoses, including high-risk patients. We went through the transition of different payment models where we assumed more financial risk by being eligible for shared savings. That means if our medical expense ratio was below our target cost, we were able to share in some of the savings. As we took on more financial risk, we were able to use some of that savings we received to add transitional care programs and improve data analytics. Our schedule improved and we actually started to see fewer patients per day. As our practice developed, we became better prepared to enter into a full risk arrangement with our partners. Full risk means we share the surplus or the deficit based on targeted medical expense ratios. Fortunately, we were able to achieve shared savings and it became easier to care for patients. We added telemedicine to the practice and are currently enhancing our data analytics and reporting. Working this way keeps us more informed about our patient and spreads out the work more efficiently across the staff. For me, it's been fun to be a part of a process in which I feel I'm able to practice the way that I had always dreamed of practicing primary care. Not only do we have more time with our patients, but this specific style of medicine creates more contact with patients and helps the staff function as a team.
I'm surprised you've seen such a difference. Our practice has been going through these changes, and to be honest, it all seems very burdensome to me. I've not noticed a difference in our day-to-day routine. We have so many payment arrangements and payers we work with that it's hard for the staff to keep up with the different quality measures.
Yeah, I'm sorry to hear that. Why do you think your experience is so different?
Well, compared to Bree's experience, I found the changes more challenging. We have incorporated a care team approach, which is a step in the right direction. However, we haven't changed the management of our patients to a single value-based care approach. Therefore, it's hard to keep up with documentation required based on the patient's model. We're in a bonus program in some plans and have increased our risk in others, which makes it hard to keep track of them all. The benefit of being in a large hospital system is that I really don't need to keep track of the different programs. We have a large care management team and population health department that does that. However, I don't feel as involved with the decisions the practice makes and follows. We get reports and prompts in our EMR to help us know which patients need preventive or other services. And we also get prompts to help us do risk coding properly. Some of these prompts are helpful. However, the data given to us from payers that are used to measure patient outcomes sometimes do not make sense clinically. Also, our salaries have remained unchanged and our schedule is still built on the old model, so we're seeing the same number of patients per day.
Well, how about you, William? I don't know how you managed to stay in an independent practice and transition to value-based care. How's that even possible?
Well, being in private practice with my partners, every penny counts. Now, we're in a shared savings model, which is along the value path. We haven't decided to move to full risk quite yet. Now, we started by hiring a practice administrator who knew how to work with data analytics and focus in on documentation. Now, we also have incorporated telemedicine like Bree. After some careful research and discussions, we picked strategic partners to help with implementation. The administrator knew how to work with payers and use their data and resources to our advantage. Our administrator built a combined report from all the payer reports, which is presented to us when the patients come in for visits. This shows what services our patients may be overdue for and key quality metrics that apply to that patient. The payer provider risk score is incorporated into that report. Now, we see fewer patients a day with increased revenue because we're able to interact with more patients through additional care support. We have a care manager in the practice who helps us with our highest risk patients and facilitates referrals to the payer care managers as well as community resources. This reduces the cost burden to the practice. And when patients can't buy food, they most certainly won't buy medicine. And they also can't come to appointments if they have trouble finding transportation. This shows how much patient involvement also affects the model. So we spend a lot of time through care coordination, patient education, and addressing social determinants of health. Now, we're working with our partners on pilot programs to help alleviate these concerns. A benefit of increased revenue we have seen from our contracts in cost control has allowed us to hire additional personnel to handle the administrative work. So far, this is working well.
I agree. It can be difficult to engage patients that are not accountable for their health. However, by focusing on social determinants of health, we can improve patient engagement and overall well-being. Our staff screens patients for isolation and food insecurity prior to their visit with tools available from the CDC, which are integrated into our EMR. I can address issues during my visit, and our social worker becomes involved to make sure the patient knows which resources are available and how to access them. The plan's well documented, so my team and I can make sure to follow up. Collaborating with quality partners contributed to our success. Everyone in the system, from physicians, hospitals, payers, and most importantly, the patient, benefits from the model working successfully.
Now, Bree, remind me how you started getting involved.
Sure. Since I'm not an independent practice owner and don't make the final decision on workflow, scheduling, and adding programs like William, I decided to learn more about the model and ask questions as soon as we started having meetings about this topic. I just thought it was important to be a part of the conversation since the changes would directly affect me and my patients. By gaining more knowledge, I have been able to understand this space better, so my colleagues elected me to represent them in discussions with our administrators and partners. I'm lucky to have very engaged colleagues who meet regularly. They know what is happening each step of the way and feel comfortable giving feedback. Our physician administrators are happy to have someone representing those of us in practice because we have been key to finding realistic implementation strategies. We had to work a little harder on negotiating our schedule and financial incentives, but we're able to come up with an amicable solution. It takes a little extra time learning about this new payment model and innovative ways to deliver healthcare to our patients, but it has been rewarding. It is nice to feel like I'm helping my patients and I'm learning something new at the same time. Communication and transparency is so important.
I'm glad that you can show me a different perspective, Bree, because I came into medicine to practice clinically, and I've always just wanted that to be my focus. Medicine is changing so rapidly that sometimes it can feel overwhelming trying to keep up with everything. It's hard to think of finding extra time, but I am curious to learn more now.
Jeff, that's a great start. I may not agree with all the changes that are happening, but I do understand it better, and I'm seeing the benefit of being more involved. Our patients are more satisfied with the efficient workflow, and increased resources help improve the opportunities for care. In this new model, we could slowly focus on the things we always wanted to, such as high-risk patients, population health, and telemedicine, which we couldn't do in the old model.
All right, well, it's been great hearing about your experiences. Now tell me this, if you had an audience of physicians, what would you tell them about value-based care, or what did you learn from each other?
Well, it's important if you're in a large practice where you don't make the final decisions to make sure that you understand some of the basics of value-based care and the changing landscape of healthcare. If this isn't already in place, find a way to make your voice heard by looking for someone to represent you, or maybe you become the leader. It's helpful to have an open mind, even if it seems confusing and overwhelming. I've enjoyed being a part of this process and have made it a part of my professional goals.
I learned that I need to ask more questions and get involved. It sounds like physician engagement helps advance positive development, which is very empowering. It's time for me to reflect on what I want from these changes. I attend conferences that have practice management and reimbursement lectures. I usually stay clear of them, but now it's where I'm going to start.
Meeting the needs of our patients can be quite complex and difficult. Now, I used to feel our practice could do it all on its own, but we have embraced partnerships which have been successful. It is vital to choose partners wisely and collaborate with those who share common values with the practice. Consider partners who are forward thinkers in reimbursement and innovation. Now, our practice is at the point of reassessing our programs to see if any changes need to be made. We're specifically focusing on prevention. And we are happy in the shared savings model, but need to review what full risk means to us.
All right, thanks everyone. It was great chatting. We'll talk soon.
Thank you, Tanya.
Let's discuss the transition from fee-for-service to a value-based care model. Payers' value-based care programs may vary on measures and compensation, but they encompass a similar spectrum. The first step of a value-based care spectrum is typically a bonus program where the practice gets used to meeting quality measures and figuring out how to track and incorporate them. They have no risk in these contracts, but receive bonuses for quality measures that are met. It's a good place to start by changing the focus on prevention and chronic disease management. This program is also a good way to assess what administrative services and personnel are needed to meet these goals. The reward incentives can be used to help fund these new services. From here, there are many steps along the value-based spectrum, with the next crucial step in the process being shared savings. This means the practice receives a portion of its savings for reaching the MER target, or even more savings if below the target. But the practice does not see a decrease in revenue if those metrics are not met. It allows the practice to manage the cost of their patients' care without taking the financial risk of a full value relationship. This step incorporates population management. And finally, the full value relationship completes the spectrum. After investing the time, staff, and resources in the earlier stages, the practice is ready to assume full risk for the cost and quality of the care delivered to their patients. As my friends mentioned, remember, keep learning and be engaged. Align on quality metrics. Hire appropriate staffing. Collaborate with quality partners and move to a team-based approach. Consider moving to a single value-based care approach and a single report across all payers. Focus on prevention, chronic disease management, and population health. In summary, a positive and successful experience in value-based care begins with learning about the model, becoming involved in the changing landscape, integrating key partnerships, since we can't do it alone, and knowing value is about our patients and it starts with us.